Hello and welcome everyone. You've made it to part 4 of our recovery series. Before we dive in today, we do want to start off with 4 polling questions. So I'm going to launch the first one here and you should see that on your screen. Go ahead and answer the best you can. Five more seconds. And from this polling question, seeing a great mix of folks on the line today. Thank you so much for joining us. Second polling question, live now. Five more seconds. All right, about 80% of folks calling in from urban areas today. Question number 3. And 5 more seconds. So about 70% of us are from British Columbia and another chunk of folks from another part of Canada. Last question here. Five more seconds.
Down outside? Just till 1.
Okay, and about 70% of folks are saying yes, and then a mix of some of the other responses. So we'll be addressing this question later on in the webinar today. So thanks for answering those. I'm going to go ahead and get started with the presentation. As I mentioned, you've made it to part 4 of this series. In the first 3, we covered maintaining and initiating recovery. We talked about awareness and celebration. Last week, we had a deeper dive into conversations surrounding options for folks. And then today, getting into some of the underserved and vulnerable populations. And we have some specific questions to our panelists to address these pieces. Before we get started, on behalf of all of my colleagues in the Lower Mainland today, I want to respectfully acknowledge the land on which we're working as the traditional territory of the Coast Salish peoples, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. As always, if you've been following us in this recovery series, I do want to take this moment, if you're in another part of the province or in another part of Canada, just to reflect on where you're on, which territories that you're listening into this webinar, and giving your thanks and gratitude for being there. So as I mentioned, this is a 4-part series. If you haven't had a chance to listen to parts 1 to 3, we do have those live on the BCCSU website. So you can go find those at any time, watch the recordings, the slides, they're all there for you. But thanks for joining us for part 4 today. So the format of this discussion is just to do a really quick introduction of our amazing panelists. Then we're going to dive right into the discussion. So we have some good questions for our panelists. And then we'll leave you some time to ask your questions. So in the chat function of this platform, you'll be able to ask your questions. You can do so at any time, but we'll loop back around to those at the very end of this session today. Now I'll start by introducing our panelists today. So we have a number of folks on the line. First, we have Dr. Jenny Malamed, who is an addiction physician and co-founder and co-medical director of Precision Medical Monitoring Limited. Since 2004, her practice has been fully devoted to addictions and pain management. In 2019, she received recognition from the College of Family Practice after receiving a certificate of added competence in addiction medicine. We also have Ann Livingston, who's the Executive Project Coordinator for BC Yukon Association of Drug War Survivors. Ann is a community organizer who works to improve access to citizenship for people who use drugs. After co-founding the VANDU in 1998, she was employed as VANDU's Executive Program Director for 10 years. Ann has organized with people who use drugs to form several drug users groups, including BC APOM, WARS, the BC Yukon Association of Drug War Survivors, and Kaput. And has opened 4 unsanctioned overdose prevention centers. We also have Rhea joining us today, who's a writer, an activist, and a person with lived and living experience. She has served as a peer consultant with the BCCSU and other community groups, and she sits on the board for the BC APOM. Rhea identifies as a harm reductionist and a person in recovery, and participates in a number of support groups like LifeBring and Harm Reduction Work. We also have Amanda Stoller, who's an addiction counselor. She's also a published author of Mothers, Mothering, and Sex Work and Releasing Hope. The last few years, Amanda has demonstrated her passion regarding the overdose crisis, where she's developed and facilitated peer engagement groups, finding ways to have meaningful relationships in community. So if you've been following along with this series, you know that we have 2 panelists also joining us throughout these series, and that's Jessica Cooksey, who's the Operations Manager of Last Door Recovery Society, and as well Carson McPherson, who's the Executive Director of Cedars at Cobble Hill. I myself, I'm Amanda Giesler, and I work at the BCCSU leading our education activities, and I'm co-moderating this session today with Giuseppe Ganci, who's the Director of Community Development at Last Door Recovery Society. So with that, you can see we're in very good hands with a robust panel and others joining us today. So with that, I'm going to pass it over to you, Giuseppe, to walk us through the questions and discussion we have set for part 4 of this recovery series.
Well, thank you, Amanda, and thank you to everyone that's been participating in part 1, 2, and 3 and has made it here for part 4. Special thanks to the BCCSU, who's provided this safe space for us to have these conversations, and also want to do a shout out to Minister of Mental Health and Addictions, Judy Darcy, who helped get these started as well. You know, we want to continue to have that conversation about the recovery process and how recovery is change through which people improve their health and wellness. I want to start off by saying there are many pathways. I emphasize there is no one pathway. These webinars were created because myself and some of my colleagues saw some gaps in the messaging in Canada about how we can better initiate recovery in people who ask for help. And some people are asking to have reducing their drug use. Some people are asking and inquiring about what policies there are for medication-assisted treatment. And also when someone's asking for abstinence and says, hey, I want to stop using. And we saw some gaps in there. And unfortunately, people who use drugs, service providers, we're all fighting for space and we're all fighting for funding. This has fostered some deep consequences in our country. As a recovery advocate myself, when I rally for recovery and rally out loud, sometimes it appears that my message may be not inclusive or maybe against something. And for some reason, sometimes when we hear harm reduction advocate messages, we get this idea that they also are implying that it's my way or the highway. It's a call to action. I'm really hoping that these webinars and the future of conversations when it comes to addiction and recovery is that these webinars help build community. And my call to action is that we all create effective alignments between the many and 2 pathways. And hopefully we build recovery capital in those that wish. And so we can collectively continue to save lives. I'm hoping that Twitter and Facebook do not create drug policy forever. And this is just a small moment in time. And I really hope that we have the conversations about initiating recovery today in part 4 for vulnerable populations. We're going to start off with Jenny. Hello, Jenny. Welcome to the webinar. Jenny, you are one of the largest opiate and oxygen therapy programs servicing the Surrey Strip, 3 decades of helping people. Everyone knows that addiction treatment is different for people depending on your financial and social capital. That's not right, but it is what it is. What blind spots have been created because of this siloed, defective, de facto two-tiered network of services?
Well, in the province of British Columbia, we've got two camps when it comes to the approach towards the management of substance use disorders. We've got harm reduction on the one side versus the concept of remission or recovery. And please, when I talk about remission or recovery, I'm including everybody who's on opiate-assisted treatment. I do consider people who are on methadone and Suboxone to be in remission and be in solid, stable recovery. I work with people continuously who are on methadone and Suboxone. Okay. Everyone agrees addiction is a chronic disease similar to diabetes, hypertension, and heart disease. And all of them, except for addiction, are focused on research, treatment, and approaches to their management, which are oriented towards remission, and they've all got integrated systems of care. But in addiction, we've got no overarching principles to uniformly direct our approach. And for me, this is disappointing because we should be talking about a continuum of care. Okay. We need to establish unbiased and comprehensive approaches focused on achieving best outcomes. Okay. We know from the work done by Julian Summers, who's based at Simon Fraser University, that many people want the opportunity to achieve remission and to be given the opportunity to stop using substances and live substance-free. We also know this is possible. In the Canadian Life in Recovery survey, 58% of people achieved remission, and most of them did it without medical intervention, such as seeing a doctor or opiate-assisted treatment. When we add medical interventions, up to 80% of people achieve this outcome. So for me, it's important to remember that physicians, we're educated to treat disease. Okay. You look at medical students, minimal time is spent teaching them about the substance use disorders when they're in training. Recovery is more of a wellness entity. And besides the prescribing of medication, which the doctors and now nurse practitioners can do, the majority of recovery is better done by individuals who themselves are in recovery, such as those affiliated with mutual support groups, families, counselors, treatment centers. We're not the primary people who should be doing this. Okay. Our current system is in the vast majority only doing research and providing guidance primarily on harm reduction interventions. This shouldn't become the de facto standard of care. We need to embrace all forms and what, as Giuseppe said, what everybody is looking for, because everybody has a different idea.
Everybody is definitely unique. There are so many, we're all different, and thankfully so. So in the Surrey Strip, as a physician, vulnerable people in the Surrey Strip, they say, how do you initiate recovery in helping people that came off the Surrey Strip are now in housing? What are some of the processes in initiating recovery in people that ask?
So you must remember, I've worked in detox, I work in this at the clinic. Most of the people who come to us in those situations are already people who've made the first step and they're initiating their request for help. Okay, but it doesn't help for me to say, here's methadone or Suboxone and go home. The most important part of treatment, which all of you understand, is your therapeutic alliance, your relationship with your doctor, your relationship with your therapist. So we really strive for recovery-oriented systems of care. We don't fire people, terrible word, I know, but it used to get used, for not becoming sober. We don't disengage with you because you continue to use substances. We don't decrease your methadone dose because we're punishing you. This isn't about that form of treatment. Recovery and addiction itself is a very difficult disease. And it takes years for people to achieve sobriety sometimes. Sometimes we move forward, sometimes we move back. But honestly, if somebody came into me in the beginning and they were using every day, 4 times a day, and we're now down to twice a week, once a day, heck, we've gone a lot further than we were before, okay?
Yeah,
and I celebrate everything.
Time has definitely made some changes. Conversations like we're doing right now is making those changes. 10 years ago, it was different. 5 years ago, it was different. You know, there have been some mistakes made and some bad mistakes. And I think the entire industry, from providing services to those that are underserved and vulnerable to people that fly airplanes and do surgeries in hospitals, you know, we're all learning by dialogue, and that's one of these opportunities that we have today. And there are many forms. You know, I was talking to a doctor yesterday and said, you know, with any healthcare issue, there are steps. With addiction, it doesn't have to be the 12 steps. It could be many other steps and so forth. And I wanted to now have a conversation with Anne. Anne, you know, I hope we're friends, and I think we're friends, and we've known each other for a long time, and I love following your conversations on social media and so forth. If anyone's going to talk about initiating recovery in underserved and vulnerable populations, and you're the first person to come to mind for me, how do social inequities that cause poverty and housing insecurities impact people's ability to access recovery services? So how are we helping someone that's got a credit card can go to treatment, but somebody that's in a vulnerable position that doesn't have that ability? How do we initiate recovery in them, and what are some of the obstacles, Anne?
Well, it starts with the obstacle of simply not being on welfare or being housed at all. And that means you usually don't have any medical coverage whatsoever. So they can't even access harm reduction recovery that's like out, and they can go to an OPS. I mean, the whole function of this idea of starting user groups and having injection sites and overdose prevention sites, if you did a survey, you'd find that most of them are pretty much facing many, many social barriers, and at least a third of them in my surveys aren't even on welfare. So I think the obstacle that isn't talked about much is that they have criminal records, that they are constantly rearrested for red zones. They're released on conditions. Often the conditions are that they not use drugs or have drug paraphernalia on them. I don't know how they're getting away with this because it's tantamount to murder. But so we have a lot of issues right there, and I think that the recovery community would be wise to take a more advocacy role, and that if we can do that in a united way through all of these services, people who are powerless are powerless. That's exactly why they're vulnerable. And when they go to make any complaints about anything, they either can't get the complaint through to anybody, but there's basically no one to take it. You would have to be a genius to be able to figure out how to take a complaint to the College of Physicians and Surgeons, then do a complaint to the pharmacists, and we do them and we get nowhere. I'm just saying, I have access to technology to do that. So I don't know if people know that the Drug War Survivor Group and many of the drug user groups are simply set up to do education, advocacy, and support. So the advocacy part of it is what I see is missing, because we can have poor quality in anywhere. I mean, the recovery, the abstinence people must just be horrified when they hear what goes on in recovery houses. But often in the public or everyone's eyes, they think, oh, it's all the same. And they don't realize that if you go to Edgewood or Last Door or whatever, you know, that you're going to get a high quality of care. They just know that there's low quality, so they think it's all the same. And people who have those experiences have a very difficult time going back.
I'm glad you said that, because a common thread on hashtags and social media, it's like, you know, if you have a broken arm, you go to the hospital, they fix your broken arm. But when you have addiction, it's completely different. There's no one way, like you can't just fix addiction with one intervention. So, and let's just say you are the Minister of Health, and you've got the ability to make some changes, and you're talking about complaints and so forth, and accessing services and the mishmash we have right now. What are some of the, like, maybe just two important things that we need to start with? Like, how can we improve that system of care?
Well, I think that we can't keep ignoring the fact that people are criminalized, and certainly, you know, alcoholics are less criminalized, but they're still criminalized. If you drink outside, you get a ticket. You don't pay the ticket, and you'll get picked up on a warrant. Just saying. I don't know if people realize that. But I think that we need to stick up for people and make it clear that they have a system that can be accountable, and it is accountable, and it will be accountable. Right now, there's not even an overseeing body for, say, Vancouver Detox or any of the detoxes. So if people tell me they went to detox and they got kicked out, I have almost nowhere to go, even as an advocate. Where am I going to find out what's going on? And no one believes these people. You have to realize they're completely lower than a snake's belly. They're universally hated. They're not believed no matter what they say. They're always accused of drug seeking. So I think that's the first thing that I would put into place. But I would begin a very, very stern conversation with the police and the courts, because you will not see interference in people's health care, whether it's addictions or bloodborne pathogens that have usually been gained by having injecting drugs. Then they can't get access to many, many other parts of healthcare, including access to treatment for their substance use disorder.
You know, we talked briefly about that the other day on how we have licensing, we have accreditation, but we don't have this overall system of overview for the addiction treatment recovery industry and so forth. And hopefully, you know, one day we get there and everyone that's involved as a stakeholder can participate in the creation of that. Raya, welcome to the webinar. I want to ask you, so you know, we had a conversation about Recovery Day and recovering out loud. Why is it important for you as a person on OAT to be visible?
Thanks, Giuseppe. Yes, we did talk about that, and so there's a couple things I kind of want to touch on here, because visibility is such a, like, there's so much, right? So I've got some notes so that I don't go completely off track. So we'll see how this works. But the first thing I want to touch on is, you know, my personal journey and empowerment. And then the second thing I'm going to touch on is what I think Anne already kind of touched on, which was, you know, visibility is a way to look at privilege and raising awareness. So I think those two things are really important here. So, you know, for me personally, you know, OAT, opioid agonist treatment, you know, you've got your methadone, your Suboxone, your Cadian, etc. So that is really just, you know, it's a tool, and it functions to provide, you know, stable, long-acting relief for folks with opioid use disorder. So, which is what I had. And of course, it was a big secret and nobody knew. And I didn't know how much that secret was killing me. So, you know, on a personal level, accessing OAT for me, and I'm on Suboxone, was very difficult. And I experienced so much internal resistance and anxiety. And I didn't understand until later that it was shame, really, when I unpacked it. So it was shame. And it was sort of this self-stigmatization, which is really internalized public oppression. So what I ended up doing, and I really didn't have anyone to talk about it with. I found like anybody who's been into a methadone clinic, a lot of these private clinics especially, which was a couple of the ones that I went to, they're not low barrier, right? So it requires this sort of like shifting of your life in a very extreme way. They refer to methadone a lot as liquid handcuffs. And so when you really start unpacking all of this stuff, you know, the daily witnessing, the clinic fees, the disrespect that, you know, you can sometimes get from, you know, clinic staff, certainly the disrespect I witnessed, you know, towards, you know, people around me too, lineups, no appointment times, stuff like that, can really create an environment that feels very oppressive. So that was something I recognized. So I guess what I'm saying is that my resistance had less to do with the medication itself and more to do with all of this other stuff that was going on that I believe can be sort of dismantled and, you know, reconstructed.
And that's, I just wanted to touch on, that's the power of advocacy, where, you know, coming from the gay pride movement when I was 16 years old, it's like sharing our stories, like we exist, even though 90% of the world doesn't want us to exist, like we exist. And I felt the same way with Recovery Day. It's like, oh my goodness, like look at all these people, like-minded people. And, you know, the same thing with people on OAT. It's like, Recovery Day isn't about my story. Recovery Day is about all of our stories together. And so how do we ensure that somebody who chose abstinence feels respected at Recovery Day and someone who's on OAT feels respected at Recovery Day? How has being an advocate empowered you to live the life that you want to live?
Well, yeah, exactly. Like one of the things that I did, so what I did is I chose to lean into the discomfort, right? And really lean into it hard. So I found a group, because I was looking for a support group around OAT. I found the BC Association on Opiate Maintenance, which is actually an activist group whose mission is to improve the quality of life, defend and protect people who are on OAT from prejudice and discrimination, stigma, things like that. So, so that's given me something that I didn't have before, which was meaning and purpose, right? So essentially, I needed a reason to live my life, and I didn't have that before. And there's a lot of things that it gives me, right? So it gives me an opportunity to do service work. So, using my skills and my privilege to raise awareness and push for change. Eventually that can also look like, once I understand where I stand, then I'm better positioned to elevate the voices of those who are more oppressed than I am. And
it also helps when you understand the position you're at, but then it helps everyone understand that position as well. So, I really appreciate everything that you're doing. We're really hoping that this year at Recovery Day, there's a presence from your organization, and out of all these webinars, that's one of the things that's coming out of this. So more power to all of us in building that community of unity. Amanda, welcome to the webinar. As a former sex worker, what was it like initiating recovery for yourself in the early years? And what is it like, for when you were working in the downtown east side? How has it been initiating recovery when you were still using and so forth? I know this story is a book, but how can you do that in 10 minutes?
So in the early 20s, when I was like around 22, 23, I remember trying to get well, get recovery. I also was pregnant. I was wired, and I remember that, going into the hospital, having a baby that was, born dependency on opiates. I had this timeline. I remember not being able to really speak to myself or know what I needed to do in order to get the needs that I needed to be met at that time. And so with that, all I remember is that I just wanted to get high, and I left the hospital. 25 years in the sex trade work, from escorting to a foot from the curb, if you will. There's many different stories all around that, but at the end of the road, when it came to getting well, and Anne spoke to that, the social barriers, criminal records, having red zones, not having any education, marginalized, and all the stigma and all the things that come with that. I remember I didn't know what to do. I had no ID. I didn't have anything. And what happened was that just by chance, my sister came back into my life, or I came into her life, however that happened, and I started running. I remember trying to put a few things together. And so to answer your question, I think it was really hard for me to kind of get going into the direction where I needed my needs met with all the barriers that I had. And then once I was able, and I detoxed on my own. I remember the detox keep calling back, and I'm going into full-on withdrawal. I don't really have any access to different things where I was at that time, and I detoxed without any medication. I don't recommend that, but the life that I have today, to be complete abstinence, I didn't know that was the pathway that was going to happen for me. It was kind of chosen for me. I didn't really pick it. I know when I was incarcerated, for years, you know, I was highly medicated and I was on everything. And I know that when I wanted to do different things to taper or come off or to get off other medications, I had other barriers, you know, because they want, like, they'll throw you in the hole if you start refusing your medication.
So Amanda, I want to ask you a quick question, which is, fundamental and one of the reasons why we're doing these webinars. As a vulnerable person, underserved, all these barriers, are we at a stage where the healthcare system helped you initiate recovery, or was it people? What would you say to that?
People. It was people. Strangers kind of just started showing up in my life in Kelowna, and like I said, I hadn't seen my family in like years, like decades. I mean, I have 4 children, and I saw my daughter at 17, the one that I left in the hospital. I have an oldest boy that he was 27 at the time, and I was able to see him and kind of speak to a few things. So, and then I have a 13-year-old and a 15-year-old that I hadn't seen since they were like 6 and 3. So it was a couple of people that started rallying around me. My sister kind of told me that I needed to drop me off at the Llano Club. I wasn't happy about that. I had nowhere else to go. I was 42. And there was a few women that started showing up in my life and cheerleaded me. And then I started running. I'll keep going back to running because I didn't know what to do with myself. And I was broke. The only reason why I had a disability is that Dr. Eves put that together for me when I was incarcerated. Like you said, Anne, I wasn't on welfare either, and living a lifestyle that was illegal and a lot of stuff that goes with that. You just and you're not. People don't believe you. Your words are incredible. They're thinking that you're trying to find a quick buck or drug seek or take a shortcut, and what you see is what you get. Necessarily, it wasn't. Even when you were speaking the truth, there was always, people, questioning what your intentions are. But these people believed in me. Yeah, these other people believed in me.
How do we blend what's happening, with Raya's conversation and lived experience, your lived experience, Anne's lived experience, Dr. Jenny and the patients that she sees? How do we build unity in all lived experience stories? Carson, I wanted to bring you on, and Jessica, welcome to the webinar. There's another question on the deck, and maybe Carson can touch on it, listening to Anne and Raya and Amanda's story. What interventions should the government be paying for? Should they be paying for it? How are we doing in healthcare when it comes to doing interventions on people that are asking for help?
Yeah, I mean, that's 3 questions, Giuseppe, so I can't just soundbite that one for you. But, I'll say this. I think the healthcare assessment sort of vehicle to get people assessed and into care is very poor. I don't think that's, Jenny touched on it. Dr. Melamed touched on it, that, addiction medicine for physicians is, arguably completely absent. I mean, it's maybe a few hours, but there's certainly nothing on recovery and how you actually understand the soft skills to motivate and work with someone over a period of time. Because we all know that those of us in recovery, we've got those windows of motivation and they're not always there. But working with someone, developing that therapeutic alliance so that they're there, when they are there, you have a trusted person and source that you can speak vulnerably and open with, and that can help you navigate what is, a very broken system. In terms of the interventions that are applicable and where and when, I think that's a decision between practitioners, healthcare professionals, and the person struggling. There's multiple pathways to recovery. I think that's part of the challenge. We talk too much about defining the word and as opposed to actually collaborating together, not on social media platforms, but coming into environments like this. My experience is that, there's a lot more rational thinking than meets the eye if you just look at the discourse that you see in social media platforms. I think people do want to come together. The challenge that we have though is that, you know, you and understandably so, 2014, 2015, you have overdoses coming on at a rate that's unprecedented. Everyone's on their back foot. And we responded in a way to try and save lives. But I mean, I think it's worth asking, you know, what is the challenge we're still fighting? I believe obviously that's still one, no one's denying that. But just saving a life, that's not providing life, you know, and those are very different things. And so I think keeping someone alive is very important. But part of the problem, and I agree with what Anne said, you know, we do need oversight and accountability. And I agree with Anne's point about the recovery houses. There's a lot of, you know, very, you know, unfortunate operators all over the spectrum, but that isn't limited to just recovery services. That's the entire spectrum of care. And I think there's enough good actors in the system that, you know, if we can all come together and start to collaborate on the things that we know that, hey, we're trying to achieve the same thing. Someone's struggling, you know, when they were a child, their parents didn't envision that for themselves. They didn't envision that for themselves. Let's try and get them into a quality of life, which is effectively the only thing we know in the research that maintains, you know, sustainable managed recovery. But what that looks like for each individual is different. You know, OATs, you know, whatever it matters, from the harm reduction to abstinence, it is a continuum. And the reality is someone moving and pursuing along that is, you know, that's a journey that's individual to them. My challenge is that because we are so entrenched in these sides and philosophies, I don't think we understand what problem we're even solving half the time. And I think a lot more of it to do is politicized than it is to do with healthcare. You know, and the person who ultimately suffers in that is the person who's been suffering all along, right? And that's a really unfortunate perspective of all of this. You know, I agree with what Dr. Mellon said too. OATs is recovery. No, I don't think that's even the debate that it was a number of years ago. But we still have to talk about that as if it is still a question out there. And I don't, you know, in inner circles, I don't hear that as a question that goes around.
Yeah, we want to make sure that in part 2, Jordan V's story about how her doctor wouldn't meet her needs on OAT, and then we have Raya's story where she had difficulty getting on OAT and so forth. Like, those two stories need to get squashed, and so it's person-centered.
And I think that when you're talking about vulnerable populations, what Dr. Mellamy spoke to is that we put a lot of onus and pressure on the healthcare system to solve the social detriments of people who use substances and other vulnerable populations. We can prescribe medication, we can provide access to bed-based services, we can reverse overdoses, but without a collective systems-wide commitment to supporting people's wellness and quality of life, we are literally only saving lives. And that means something, but without people who are going to lean into it, not everyone has the capacity to lean in to the stigma that we all encounter and the barriers that we all encounter. People do not recover through the healthcare system alone. You know, when we're talking a lot of focus on Surrey and the epicenters that have really championed and leaned into what we need to do to change people's quality of life, but there are multiple vulnerable populations across Canada. You know, I'm a little fired up because I see, you know, MLAs doing a call to action and standing up for people's rights. But to me, you know, there's domestic abuse happening across Canada in all of our communities to people who use substances. And I don't see people standing up for us and our needs. You know, I see pockets of advocacy and making meaningful change. However, putting the onus on the healthcare system is, you know, it's like we need a full system of services and supports for people who need access to recovery supports, need access to the medication assisted therapy. So when we're looking at those vulnerable populations, you know, we need to look at Canada as a whole and our province as a whole, because it's really easy to focus on the good work we're doing locally, but that doesn't expand out yet.
I wanted to bring Amanda back to the platform to see if there's any questions and answers. Amanda, are you available?
Hi, yes, I'm here, and we've got lots of questions in the chat, so we'll get through as many of these as we can. The first one I have here is for Dr. Malamed. So Dr. Malamed, the question says, there have been reports published saying that there needs to be significant changes to the way we treat employees with substance use disorders and how we support them to return to the workplace. What can be done to ensure that British Columbians are able to access a variety of individualized, patient-centered, ethical, and affordable supports that meet their treatment and recovery goals?
Are you talking about safety-sensitive workers here, Amanda? Is that what the question is asking me?
It's saying supporting employees to return to work. So maybe you can touch a little bit on that, but generally employees.
Yeah. Many employees actually, like if you work Safe BC, and in many situations, you actually have a facilitated return to work because your employer supports you. There is a requirement for certain people who are in what we call safety sensitive occupations, which is an occupation where if there is harm or something goes wrong, you can harm the public. Those people need to be accountable when they return to work. So it's not that there isn't the support out there, it's just that it may be in a different form. And I can't address that in a 2-minute answer at this because it's an entire webinar on its own. But there are people who do return to work in some situations on methadone and Suboxone, and there are some professions where it's not permitted. These are not decisions that we as physicians make. This is set by the American and Canadian Occupational and Environmental Medicine Associations, and there are guidelines that we need to follow. Same as the way there are guidelines when people are on being prescribed methadone or Suboxone, and especially with methadone, where we know from day one you've got to go low, start low and go slow. So we have guidelines we need to follow. So there are ways that, and all workers, we know that people benefit from work. We know it is a healthy thing for them. And it's not that we can lay these out. There are guidelines that we follow.
All right, maybe Anne, we'll pass this question on to you, and it's talking about trauma-informed approaches. So the question says, what about a trauma-informed approach to substance use disorders? How are we addressing ongoing genocide and the impact of trauma on Indigenous bodies and families?
Well, I'd say that we're not. And I think that, again, if you look at the way the system works, we're leaving out the criminalized part of the system, which is that we've got a way disproportionate number of Indigenous people jailed. And if you look at health outcomes, whether you're Indigenous or not, your health outcomes are terrible if you go to jail. And we know why. When you take it apart and listen to the people that go through this system, they're the only ones who know how the system works. So I'm a person who had to ask all those questions. I had to make extensive notes, and then we had to start to look at the choke points. I think welfare policy is one of the most murderous policies we have because it denies people health care, and it also denies people everything in the sense that if you have no hope of even getting any kind of income. So people, the welfare policy could change and get people with disabilities access to, if substance use disorder is automatically put you on, especially when we have an overdose crisis. So I think that the more marginalized voices by race, when we can tease out the ones that are so obvious. I mean, for a more privileged person, if the worst thing, they have a glass floor, the worst thing that's going to happen, they're going to live in their parents' rumpus room and be made fun of because they're 40 and they've never had a job or something. That's a pretty nice glass floor when you consider the other deaths that we're seeing that go on, and inadvertently all the way through this system. And I think that's why I'm calling for a sort of a hotline. You just call it and someone responds and they listen to you and they handle whatever it is you're telling them, because you should always believe people when they tell you that somebody made you perform oral sex or they wouldn't write your script. And if you don't think those things have happened, I'm sorry, but they have happened and they can happen and they may continue to happen. I don't think it's as big of a deal as now as it was 20 years ago, but I'm just saying we need this really important sort of standing up for, and this kind of evening out, so people have a glass floor. And it's BC, we have a social safety net that makes sure it works. It doesn't work right now at all. Release from prison has got to be the most dangerous time, and getting kicked out of recovery centers because you're not complying, or recovery houses, and then all of the mushy indifferentiation between all these things. It's absolutely dreadful. We think we don't have a system. I think we have a system that's working perfectly for the people that are dominating it. physicians make lucrative money prescribing things, medications, as do, and pharmacists dispense, and we have all kinds of trouble with both of those things, and you have almost no way of complaining about them. But it goes, you know, from it's insidious.
Systemic violence. When we talk about trauma-informed, when you talk about trauma-informed, that question, we go back when we look at every system we have causes trauma. Yeah. And so, like, I have a hard time saying, oh, we've had trauma, we do trauma-informed practices because we provide an elder inside an institution that it can forcibly get permission to search a woman's inside a woman for substances that have gotten inside a prison, where we can do things like that to women, where we can do those type of the pieces that do cause the trauma, which is also linked to the substance use. It's almost like we want to keep this going by creating systems that harm and are violent.
And we didn't mention child apprehension, which is huge for Indigenous, and I'll stop there. And I apologize that I have a carrot on my shoulder.
We appreciate your passion, Anne. Thank you. Carson, I have more of a comment, less than a question. Maybe you can comment on it. It says, perhaps we need to broaden our understanding of what the health system is to reflect some of the things that public health supports these days, like funding for drug user groups. People might feel less excluded if we can find a way to acknowledge more openly that funding like this is healthcare. But we can't hear you, Carson. You're muted.
Sorry. Yeah, it's an interesting comment. I mean, I think you know, from what I've seen, there seems to be enough resources going around. My question in that regard for drug users groups, for the advocacy piece, my question is, I mean, as Anne mentioned, a lot of the fundamental aspects, one of them being education, is, you know, what are we arming these people to educate with, right? There's a presumptive component here that we have, an assumed understanding or education, and based on what the data is, supplied by largely, insular downtown east side research, which is geared towards, pretty insular, questions. And I think Julian Summers hit it on the head last week when he said that data in and of itself is often misread and misinterpreted. And so, I would be more curious as to what, how we can support, groups that are already out there doing things, and make sure that they have the right information and the right context, because people's lives depend on it. And they're looking to thought leaders and professionals and healthcare practitioners to guide that process, to whatever extent that means for them. But I think that we're sort of skipping ahead, that there's a consistent and accurate knowledge holding across various groups that I haven't seen, and it's not in sinister intent. I think there's a lot of misinterpretation and misread of the data. And again, I think you think about the fact that we're on a webinar about vulnerable populations. You put a coroner's report out, you don't necessarily need to go through it in depth to know that women with children, women in First Nations, women in the downtown east side, individuals being discharged from incarceration, not care. Like, there's very consistent, obvious groups that are disproportionately affected that I haven't really seen any tangible, practical strategies for. I think we do a lot of talking. I think we do a lot of research on questions that have obvious answers. I really feel for the vulnerable populations that are continually left, out of the conversation, and certainly out of any practical ways in which we can add tangible, real support.
And maybe Ray, pivot over.
Sorry? Amanda, I just add really quickly, we had a meeting with Health Canada just yesterday about this very issue, and the conversation really is, and why we're doing these webinars, is to keep all dialogue open, not just drug user networks, not just recovery networks, but all narratives open. 20 years ago at Health Canada, you couldn't say the word harm reduction. You couldn't write it out. You couldn't get any funding for it. And the pendulum swung, and now it's almost, and from experience, you say the word recovery at Health Canada, and it's like, it's got to be harm reduction, and then you get in that semantics game. Harm reduction is recovery, and it's just really bizarre time right now. And the goal of this is like, yes, we need more funding for drug user networks. We need more funding for everything. And the conversation can never be one or the other. And that's why Ray is here, and that's why Anne's here. And this isn't about 12-step propaganda. It's like, if you want to get clean and sober, or whatever your terminology is, do it. And if you don't, how can we support you? And you know, the questions are creating the silos. It's like, how do we empower everybody? And I get passionate about that. Gay pride, when I started, advocating for pride, it was never just about gay men. It's always been about the entire community. And I'm using that transference here because I really hope that, the question and comment that just was proposed is about empowering everybody, not just certain. And it's not purposely done. It's an unintended consequence. And we need to snip it where we can and really need to support each other. So that's my soundbite. Thank you.
Yeah, I'm
Just
gonna
to build on that quick thought,
Giuseppe. Sorry, Carson. I'm going to pass it over to Ray at this point. Ray, did you want to make any comments?
I just want to make one comment on that. Again, I think this is where we need to look at our privilege. So when we're talking about empowering every person, that's not exactly how it works, right? So certain people have more privilege than others. Certain people, certain segments of the population are oppressed in ways that others aren't. And so we cannot raise up those voices without sacrificing some of our own privilege, right? And that is something that I don't know is really understood. And I think harm reduction theory can actually really help us there. So if you want to know what people need, you have to listen to them. You have to ask them, right? What do you need in this moment, right? Harm reduction theory has helped me so much with my capacity to care for others without my own needs getting in the way, right? So these systems and structures need to center the voices of people who are oppressed, people who are accessing the systems. So it's sort of like flipping it around in order to build it out in a way that's going to work for people.
I think Dr. Melvin, yeah.
Yeah, I want to go back to something that Ray just said, is we've approached the government because the clinics that provide methadone that do charge, okay, we just don't have the money to survive. We're not like the government clinics where the money can just keep pouring in. And we've approached the government. We started talking to them last year under a group of non-government clinics and said, you need to please find the money to cover the treatment for everybody in the clinics, okay? When this crisis started, they put us on the back burner, okay? And this hasn't been addressed. We have never in the private clinics, we don't call ourselves private, we're not private, we're non-government clinics. We have never turned somebody away at the front door. The government clinics that suddenly said, we will get you in on the same day. We have always got people in on the same day. We have always started treatment as you walk in the door and never turned you away. If you cannot afford to pay, we don't turn you away. But we believe that we carry so many of these patients. If we can get the government to put money towards this, it is so important. But as I said, we've been put on the back burner. And this needs to be looked at.
Let's just refocus about, policy, sadly, is a conversation that is a debate. So like the goal is initiating recovery in underserved and vulnerable populations. And thank you for this, because this just proves why we need to do this. Can you imagine trying to find recovery in a mess of policy? And it's set up to fail. And that's why the call to action is when you click on end meeting, like how are you adding to helping, people either meet them where they're at or start a journey of recovery. And I'm grateful that we are talking like this, because it's a very evident that we all need more work to do, and including me. Like I ain't perfect. And also the responsibility of it all. I think we all have the responsibility to not turn away and help everybody.
And to speak on Anna's point about the legal system, I question whether we have a justice system at this point. However, with the legal system, is one of the call to actions is that people don't get sentenced to Last Door Recovery Center or Westminster House, that they get sentenced to counseling as directed, so that their livelihood or their freedom, although limited, isn't attached to whether they do what we want them to do at last door. They have the ability, and their recovery journey is fostered and supported whether they're in our program or not, that they can continue to take a look at what's going to work for them. You know, and I am encouraging people to unpack the COVID protocols for people leaving custody centers. You know, I find them oppressive, quite frankly, and I question whether that's fostering connection and helping people initiate recovery or delaying it. You know, there's a lot of things to unpack when it comes to the vulnerable populations. But this isn't like the, oh, here's a lunch hour webinar. Let's talk about what changes we can make in the parts of the services that we currently provide, because if we don't stay the course, and like Rhea said, lean in, you know, nothing, it's going to stay the same, and privilege is going to stay there, you know, and it's going to be hidden and unacknowledged. So thank you for raising that up as well. And Amanda Stoller, always good to see you, miss. And Jenny, thanks for participating in this.
I was thinking about the initiating part, and I was thinking about an incident in 2017 when I was on the downtown east side, when you know, so I'm in this role, and I'm, you know, I'm reversing overdoses, and I'm meeting people where they're at, and all of a sudden a girl walks in through the door that I did time with, that I was on the street with. 20 years later, there she is, like 80 pounds, no teeth, no hair, and full blown in her addiction, and also she's HIV. And I'm working in that. And I remember like just like breathtaking, like kind of catching my breath at the same time, like giving her a hug because I hadn't seen her in a while. And I remember asking, like, how can I help you? You know, and what can I do to help you? And, you know, and also being resourceful and having many connections in my back pocket, you know, I'm able to, you know, make some phone calls and help her in a way that maybe she can, because I love what you just said, saving saving lives is not necessarily providing the quality of life, Carson. I just wrote that down. And so here I am living this life, a good life. And I remember being pulled aside and said that I was out of line and trying to offer that type of help. And I got kind of confused. I remember that feeling of feeling like, well, what am I doing here? That's like when you're trying to help people and offer them, meet them where they're at. It's okay to, you know, give them reverse overdoses or meet them where they're at with giving them supplies. But if I, you know, started wanting to help her get on to detox or treatment, that became an issue. That was just an incident that I experienced.
And that's
right.
the whole conversation.
Given we only
Sorry.
have 4 minutes left here. Yeah, no, all good. I just wanted to get through maybe 2 more questions. So one's really quick and I can answer this one. It says, what are the way we can continue this conversation with the speakers? Is there a way to email them? So yes, go ahead and email us and we can address them to the speakers as appropriate. We're happy to carry this conversation through beyond these webinars. And just to say that we'll be creating a recovery report with some of the questions we weren't able to get to in past webinars given our time constraints. And we'll hope to address those specific questions and provide resources in that report. There's another one here, maybe for Jessica. We'll give this one to you. It says, how can we ensure that all recovery houses are licensed and have standards working with people with opioid use disorder? These individuals are in high risk of overdose from low tolerance and relapse.
Oh, well, how can you ensure it? You can speak with your cities and health authorities and start fostering and having the difficult conversations about how we can operationalize that. All funded programs need to accept people licensed, need to follow best practices when it comes to medication assisted therapy, and that's for mental health and substance use medications. With the way things are set up, some of these assisted living registries simply don't have the funds to have the staffing model that could support people in a healthy, safe way. So that's a very complex answer that I can continue to unpack if you want to message BC's Center for Substance Use, but there are definitely a lot of actions we could collectively take to keep pushing that forward. And I do want to encourage the listeners to read up on the history of medication-assisted therapy in Canada. They're over 4 decades into it, and also to really read up on harm reduction and recovery models and all of that, so that you are informed and educated rather than reading social media, because it's quite diverse. And yeah, let's keep on keeping on and helping people.
Okay, great. There's lots of questions in the chat. So sorry we can't get through the rest of them, but as I said, we'll try to answer those in a follow-up report the best we can. To end off, just wanted to share this slide here. If you followed us before, we do share these in all our webinars, but these are links to a bunch of different resources that will be helpful. And again, these slides will be posted with the recordings on the BCCSU website if you'd like to access them. And with that, just a huge thank you to our group of panelists today. Giuseppe is the co-moderator. I think this was a great discussion. I'm seeing lots of comments in the chat that they'd like to see these conversations continue. So please let us know if these are things you want to continue, want to have conversations. We can think about creative methods and models that we can keep this momentum going and keep these conversations, as we know that operating in silos is not going to help move this work forward, but coming together and working through them is what's needed at this point. So with that, I say thank you to everyone who joined us. Thank you for joining for maybe all 4 parts. If you just joined this part, please go watch the other ones if you can. But have a great rest of your afternoon. Thank you to everyone. Bye-bye.
Thank you. Bye.
You got that poster, Anne?